topic is ECG diagnosis and localization in STEMI. So the ST elevation MA is diagnosed by the amount of J point elevation from PR segment. To diagnose STEMI, the ST elevation is different in V2 and V3, and in all the other leads, it is equal or more than 1 millimeter. To diagnose right ventricular infarction and post-wall myocardial infarction, the ST elevation should be equal or more than 0.5 millimeter in right-sided leads or posterior leads. In two anatomically contiguous leads, in the absence of other ST elevation situations, such as LBB, LVH, and other non-acute MI ST elevation presentations. So the localization of the coronary artery in STEMI is done primarily in STEMI only, with few exceptions in non-STEMI. So we have two purposes: to know which artery is obstructed and where it is obstructed, to know the prognosis as well as to plan the further management. So to know which coronary artery is obstructed, we look at the group of leads like L1, AVL, V5, and V6 for LCX occlusion, L2, L3, AVF for RC occlusion, V2, V3, V4 for LAD occlusion. So having decided which artery is occluded, then we look at V1 and AVR to know in this particular artery, where is the obstruction. So why we want to know about the proximal occlusions? Because in proximal occlusions of all the three arteries will have a huge myocardium at risk as well as the conduction system at risk. That's why we want to localize the artery as well as in that particular artery where is obstruction. First, we look at underwall infarctions, which is caused by the total occlusion of LAD, and we want to know how to diagnose a proximal LAD occlusion before the septal branch and the diagonal branch. So whenever the occlusion is proximal to S1 and D1, the primary area involved in this occlusion will be the basal areas of the ventricle, the basal septum and the basal lateral wall. Because the basal areas are involved, the ST vector will be directed superiorly. That will result in ST depression in L2, L3 AVF. So because the basal septum is more involved than the basal lateral wall, the superior directed ST vector will be directed towards right and will result in ST elevation AVR and AVL and ST depression V5 and V6. So in a proximal LAD occlusion, proximal to S1 and D1, the ST vector is directed superior and towards right. Look at the CCG of ST elevation MI, V2, V3, V4 ST elevation. So because of this, it is LAD occlusion. Then we look at the right-sided leads like AVR and V1. The V1 has got ST elevation more than 2.5 millimeter and its ST elevation is more than AVR. And we have an ST segment depression in V5 and V6, which will tell us that the ST vector is directed leftwards. The inferior leads of ST segment depression tells us the ST vector is directed superiorly. So superiorly and rightward ST segment vector tells us that occlusion is proximal to S1 and proximal to D1. Whenever the occlusion is before S1, before the S1 is going to supply the right bundle branch block, the patient has got anterior STEMI with an acute onset of right bundle branch block. Also, it means that the patient has got a proximal LAD occlusion. Let us look at the ECG changes in a mid-LAD lesion where it is beyond first septal branch but before the diagonal branch. So whenever there is a first septal branch is not involved, the basal septum is not involved. Now basal lateral wall is involved. Anyway, because of this, the ST vector is once again directed superiorly, which results in the ST segment depression in L2, L3 AVF. Here, because the basal septum is not involved, the ST vector will be directed towards left rather than right, and which will result in ST elevation in left-sided leads like AVL, V5, and V6. No longer our right-sided leads like AVR and V1 will show ST segment elevation. Now look at the CCG. V2, V3, V4 tells us LAD occlusion. Immediately look at the inferior leads. ST is depressed inferior leads. So the ST vector is directed superiorly. Then look at the right-sided leads, LVR and V1, there is no ST elevation. Whereas AVL, V5 and V6 have got ST elevation, which means the ST vector is directed superior and left. So it is a mid-LAD occlusion beyond first septal branch, but before the first diagonal branch. Then look at the distal LAD lesions. In this distal LAD lesions, the S1 is escaping, D1 is also escaping. That means our basal portions of the ventricles are not going to be injured. So no longer, because the basal regions are escaping, no longer the ST vector will be directed superiorly. So our inferior leads will not show ST segment depression. So whenever the inferior leads are not showing ST segment depression, there is no mid-LA deletion or a proximal LA deletion. Look at this ECG here. In this ECG, there is ST elevation V2, V3, V4. We are diagnosing LA deletion. We are looking at the inferior leads, L2, L3, and AVF. There is no ST elevation. That means it is not a proximal lesion. It is not a mid lesion. So it is going to be a distal LA deletion. So whenever there is no ST segment elevation or depression in inferior leads, it is a distal LA deletion with a short LAD. Now look at an LA deletion, which is a very long LAD. So there is a whenever distal LA deletion is a long LAD and ramping around the apex, the inferior wall is also involved because of this LAD occlusion. So we have ST elevation V2, V3, V4 telling us the LAD is occluded. But look at the inferior leads now. They show ST segment elevation. So here, there is ST segment elevation tells us this distal LAD is supplying also the inferior wall because it is long and it is wrapping around the apex. So when you look at the summary of ST elevation V2, V4, which will tell us that the LAD occlusion, always look at the inferior leads. If the inferior leads are showing ST segment depression, it is mid LAD or proximal LAD. In a proximal LAD, the ST vector is directed superior and to right, resulting in AVR elevation and V1 ST elevation. Whereas if it is directed towards left, resulting in no elevation AVR and V1, but ST elevation in V5, V6 and AVL, it is a mid LAD occlusion. If the inferior walls are not showing ST elevation or ST segment depression, it is a distal LAD occlusion, which is a short LAD. If the inferior walls is showing an ST elevation, it will be a distal LAD occlusion with a long LAD occlusion. So if the patient has got acute right bundle branch block with ST elevation, it is a proximal LAD occlusion. So what is the sensitivity and specificity of all these ECG changes to diagnose proximal or distal LAD lesions? There is a very good specificity, but a low sensitivity. Now we go to the inferior wall myocardial infarction. The inferior wall myocardial infarction can be caused either by the right coronary occlusion or a left circumflex occlusion. Whenever there is a right coronary artery occlusion, major injury is going to happen on the right side of the heart. So ST elevation L3 will be more than L2 ST elevation. Whereas whenever the circumflex is going to cause an inferior wall infarction, the left side of the inferior wall is going to have more injury. So the L2 will show more elevation than L3. So first we look at the RCA lesions. A proximal RCA lesion, what will be the ECG changes? So now we look at the inferior leads. Inferior leads are showing ST elevation. The ST elevation is more in L3 than L2. So we are diagnosing an RCA occlusion. How to diagnose a proximal RCA occlusion? The right ventricular branch is the most proximal branch. So whenever there's an inferior wall infarction due to RCA, V4R elevation is there. It means a right ventricular branch is involved and the occlusion is proximal. So it is a proximal RCA occlusion. So whenever there is an inferior wall, look at where is the ST elevation. The ST elevation is more in L3 than L2, so RCA. Then look at the right-sided leads. V4R is showing ST elevation, so it is a right ventricular infarction. So whenever there is an inferior wall infarction with a right ventricular infarction, it is a proximal RCA occlusion. Then we look at the distal RCA occlusion. Here, the right ventricular branch is escaping from the occlusion, so there will not be any right ventricular infarction. So in an inferior wall infarction, once again, we are looking at the inferior leads. L3 is showing more elevation, but V4R is showing a flat ST segment and upright T wave, and there is no ST elevation in V4R. So in this ECG, L3 has got the more elevation, and V4R has got normal ST upright T wave. So here we diagnose a RCA occlusion. Because of the absence of RV infarction, we say the RCA occlusion is likely to be a distal RCA occlusion. So to decide about the proximal RCA occlusion or a distal RCA occlusion, look at the V4R. If the V4R has got ST elevation, it is a proximal RCA. So if V4R is showing a flat ST and an upright T, it is likely to be a distal RCA occlusion. So even if you don't have the right-sided leads, that whenever there is an acute inferior wall infarction and there is a post-wall myocardial infarction, the reciprocal depressions will tell us the discordant reciprocal depression between V1 and V2 may tell us, even in the absence of the right side leads, if there's a discordant ST segment depression between V1 and V2, the V1 is normal and the V2 is showing significant ST segment depression. It is a sign of RV infarction plus post-wall infarction, even in the absence of right side leads. So how will we approach an inferior wall infarction? If the ST elevation is more in L3, it is a RC occlusion. Then you look at V4R. If V4R shows ST elevation, it is a right ventricular infarction plus inferior wall infarction. It is a proximal RC occlusion, high risk. If V4R is not showing ST elevation, it means a distal RC occlusion may have intermediate or low risk. If the ST elevation is going to be more in L2 than L3, it is left circumflex occlusion. As I told you, in a left circumflex induced inferior wall myocardial infarction, the injury is more often on the left side of the inferior wall. So L2 will show more elevation than L3. So that means this patient has got inferior wall infarction because of circumflex occlusion. But if you look at V4R, now the V4R will show ST segment depression and T wave inversion. So this is the important change in V4R in inferior wall myocardial infarction due to LCX. So look at LCX infarction here. The L2 shows more elevation than L3. So it is a circumflex induced the inferior wall myocardial infarction. One more change in this circumflex induced myocardial infarction, inferior wall myocardial infarction, is L1 may not show a reciprocal depression. L1 and AVL may not show significant reciprocal depression when compared to the inferior wall infarction produced by RC occlusion. So how to localize inferior wall infarction due to LCX, whether it is proximal or distal? So here we carefully look at in this inferior wall infarction where ST elevation is more in L2 than L3 by diagnosing LCX induced inferior wall infarction. Is there, so the another important thing to diagnose an LCX induced inferior wall myocardial infarction is look at V4R. The V4R now shows ST segment depression and T wave inversion, confirming that this inferior wall infarction is caused by LCX occlusion. So whenever there is a LCX occlusion which is producing high lateral myocardial infarction or anterolateral myocardial infarction, look at the sinus node abnormalities. Whenever an LCX occlusion induced inferior wall myocardial infarction or lateral wall myocardial infarction is accompanied either by a significant sinus arrhythmia or sinoatrial block or sinoatrial arrest, it is indicating that the sinus node artery is arising from circumflex. Whenever the sinus node artery is arising from circumflex, it is going to be the most proximal branch. So whenever an inferior wall infarction is due to inferior or lateral wall infarction is due to LCX and it is accompanied by significant sinus arrhythmia or sinoatrial arrhythmias, it means it is a proximal LCX occlusion. So how will you approach LCX occlusion? The LCX occlusion is producing L1 AVL ST elevation only. It is only high lateral myocardial infarction, which is low risk. When there is a post-wall myocardial infarction, it may be intermediate risk. Whereas if it is a proximal LCX occlusion shown by a sinus node problem, it is a high risk. It indicates a proximal LCX occlusion. So what is the sensitivity and specificity of all these lesions of inferior wall infarction, whether it is produced by RC occlusion or circumflex occlusion? As we can see it from here, the sensitivity and specificity is reasonably high for this type of ECG changes producing inferior wall infarction due to RCA or LCX. So individual leads also help us to diagnose the particular myocardial infarction and localization. If V4R shows ST elevation, it is proximal RCA. If V4R is showing normal ST and normal T wave, it is distal RCA. If AVR is showing ST segment depression and T wave inversion, the inferior wall infarction goes to LCX. How V1 is going to help us? ST elevation in V1 inferior wall myocardial infarction, proximal RCA. ST depression inferior wall myocardial infarction, there is an associated posterior wall infarction which may be due to RCA or LCX. Normal ST segment inferior wall and posterior wall myocardial infarction, discordant ST segment depression between V1 and V2, it is a subtle sign of proximal RCA occlusion where RCA is producing both RV infarct and post-wall infarction. If you have ST elevation anterwall infarction in V1 more than 2.5 millimeter, it is a proximal LAD. how AVR is going to help us in localization, whether it is ST elevation MI or non-ST elevation MI. With anterior ST segment elevation, AVR elevation indicates proximal LAD occlusion, where V1 ST elevation will be more than AVR. With anterior ST segment depression, it is, if AVR ST elevation is there, it is LMCA occlusion. AVR elevation will be more than V1. Then with anterior inferior ST segment depression, this AVR ST elevation, it is a LMCA with a triple vessel disease. In all these conditions, AVR is the most important lead, indicating in all these conditions, early coronary angiogram is a must rather than medical treatment of this particular acute coronary syndrome. Then we come to lead V2. In a patient which is looking in this ECG, it is looking like an LCX occlusion. L1 and AVL are showing ST elevation. In all this L1 AVL occlusion, always look at V2. In addition to L1 and AVL ST elevation, if V2 alone is going to show ST elevation, it is a classical finding which indicates an occlusion of first diagonal artery. So it is mimicking LCX occlusion, but there is V2 ST elevation. It is a first diagonal occlusion. Here, the importance of V2 in localization. So what are the limitations here? Individual variation in coronary anatomy, previous MI, collateral circulation, and so on. So the takeaway message will be to localize a coronary artery occlusion, look at the leads you hardly see, lead V1 and the AVR. Second, in anterior MI, look at the inferior leads. In inferior MI, look at the anterior leads. So if you skillfully interpret an electrocardiogram, it can be a poor man's coronary angiogram. For all this, the information, we have to thank and with the gratitude, the Haynes Valens, who gave us the wonderful knowledge and information regarding the localization of coronary artery in STEMI. Thank you for your patient listening.